Good morning, everyone. Happy Thursday. I hope you're all doing well. If you're just hopping on just now, please hop in the chat and let us know your name, your organization, and if you're from a large system, please put your facility in there too. And your response to our little community check-in. What's your favorite part about fall and autumn? What are you looking forward to in the next couple months? I'll try and keep an eye on the chat, but that's also how we take attendance for the Learning Collaborative. So please be sure to put at least your name and organization in there and your favorite.
That chart from there on out because, you know, like I got a chart back the other day, not.
Oh, there we go, Ariel. I was waiting for someone to put soup and chili in there. That's probably my favorite part. Trader Joe's like pre-made soups. Love those, the boxed ones. Thank you for joining on, everyone. Again, if you could please pop your name, your organization in the chat, and your response to your favorite part about fall or autumn, or what you're looking forward to in the next couple months. We're gonna wait a couple minutes before we get going. Mandy says spooky season. A lot of things are spooky these days. Corinne in the chat from OSP is looking forward to some scary movies. Any favorites, Corinne?
All of them. Just all of them, can't get enough.
Same here. They can't go wrong with the classics though. Nightmare Before Christmas, childhood favorite. We even have some competition between the seasons coming in there. Not ready to say bye to summer, kind of same. Again, for those just joining us, if you could please put your name and the organization that you belong to in the chat. That's how we're taking attendance today. And our little community check-in there is your favorite part about fall or autumn, what you're looking forward to in the next couple months if you feel so inclined. You can also come off mute to share if you'd like. Seeing lots of the word cozy, pumpkins, blankets. Good stuff. We've been talking about candles a lot in our office recently. Yes, I agree, Carly. The color changes. If you have any recommendations for spots we should check out, the changing leaves, that would be awesome too. And we're going to get started in just a minute here. But again, for those joining us, please put in your name and your organization into the chat. That's how we're taking attendance before we get started with the agenda that you can see on the screen here. Nice, Aspen, Grand Junction, have to check them out. I'm relatively new to the state, so these are great recs. All right, we hit 10:05, so I think we can get started. Again, if you are just joining, please put your name and organization in the chat as we get going here. Today's session, this learning collaborative is going to focus on lethal means safety. We have a special guest with us, Dr. Emmy Betts, MD, MPH, from the Firearm Injury Prevention Initiative and the University of Colorado School of Medicine. Really looking forward to what Emmy has to share with us today. As we're going through Emmy's presentation, please feel free to use the chat for any comments, questions. I'll try and facilitate asking those questions at a good point, or maybe after the presentation, we'll also have some time to chat with Emmy about any questions you might have about what she's presented. But getting right to it, our guest today is Dr. Emmy Betts. Emmy is a board certified emergency physician at the University of Colorado School of Medicine. She conducts research in injury epidemiology and prevention with special interests in patient-centered injury prevention. She co-founded the Colorado Firearm Safety Coalition and is currently developing and testing injury prevention education tools. Her multidisciplinary research group conducts research to prevent injuries through communication and connection, informed decision-making, and person-centered, efficient, and effective interventions in healthcare. Most recently, this has been the Firearm Injury Prevention Initiative, which I believe she'll be talking a bit about today. I'm excited to hear more about that. But Emmy, I will stop screen sharing and toss it over to you. Thank you for being here.
Awesome. Thank you so much for having me. I am excited to be here too. And please do put questions in the chat. I'll try to keep an eye on it too, or Conlon, feel free to interrupt me as we go through. Let me just get this going and this time. Okay, are we good? Correct view?
Yep, seeing the right thing.
Yay! Okay, super. So thank you again for having me. By way of disclosure, I do have grant funding and previously was on the Colorado Suicide Prevention Commission. I do some med legal work. I don't have any financial disclosures. The things I'm going to talk about today, we don't make any money off of. We're just developing them as part of research and as tools for the community. But I always like to start off these talks with what I consider my real disclosure, which is anytime, in my opinion, anytime you're going to talk about firearms, you need to address where you're coming from, and even if it's not explicitly stated, I think for ourselves, we need to be aware of our own potential biases and perspectives. So for me, I work in the ER at University of Colorado. Yeah, the last year and a half has been horrible. I think all of you in healthcare, right? Like we're not talking about that today, but just as we think about the mental health needs and how much worse I think it's gotten, it's hard. And thank you for everything that you all are doing in trying to improve care for patients. I see patients every single shift who are at risk of suicide. Clearly this photo is staged, but also pre-COVID. I just realized I should swap it out probably. But as a clinician, I'm always wondering, what can I be doing, especially in the ER where we're busy, we're often kind of under-resourced. How can we work with people in a way that is patient-centered and respectful, but also effective? I also am a native Coloradan. It's my father-in-law on the right. I'm not a gun owner myself, but certainly it's part of daily life or annual traditions for many of my friends and family. And so I certainly respect that, even if it's, again, not sort of part of my own lifestyle, but I do hope that my girls, when they're old enough, that they'll go hunting with Pops and learn some of the basics from him. I, though, also have lost too many people to suicide. Perhaps most importantly for me was my cousin Ian, who died by suicide a few years ago by firearm suicide. And I actually almost stopped doing this work because it felt hard to be collaborating when I was really just angry that he had even had a gun. He had lots of risk factors, and it was probably a bad idea for him to have one. And so, our family, like so many families, is still trying to figure out what else we could have done and so forth. And more recently, it feels like we're seeing more serious suicide attempts or even completions that make it to the ER. And it's just really hard and really frustrating. And this work is certainly difficult. But ultimately, it's in his memory and sort of wanting to help prevent grief for other families that I've continued to do this work. And as I mentioned, it was around the same time that he died that my work with the coalition was really taking off. And it's been probably the most satisfying part of my career, really engaging with groups who maybe previously weren't involved in suicide prevention efforts. The opportunity for me to learn about firearms, I'm really bad, but I'm trying, but also to be creative and think about how we can find our common ground. Because nobody wants to lose loved ones. And so those are my perspectives. That's where I'm going to be talking from. This is not a talk about gun control or gun confiscation, but really meeting patients where they're at and recognizing that many Coloradans have firearms in their homes. And if we want to prevent suicide, we've got to talk about those guns, and we've got to do it in ways that are acceptable to patients. So the way I often think about lethal means safety, and what I'm going to try to do today is provide a kind of broad overview just for people who are not as familiar with some of the principles, but then spend more of the time really digging into some of the nuances of what we're doing in Colorado and some of what we've been learning about how you can integrate some of this into clinical care. So I often think about lethal means safety and suicide prevention in general as someone a little lost in the woods. In Colorado, you better hope that that backpack has raincoats and all the other things you need to be prepared on a hike. But how do we, there's sort of two pieces to it in my mind. First of all, how do we really engage people and encourage them to take the first steps? Meaning, to encourage them to reduce access at home, to explain to them and their families why it matters, and really help them see why it's an action that they should take. But also, how do we make it easy? Because even if someone's willing to do it, it can be a little complicated, and I'll get into this later. But I think it's so important that we think about how we make health behaviors easier for patients so that they can actually go home and do them. So today, briefly, I'm going to talk about some background rationale, just to get us all on the same page, and then talk a bit about what we know in terms of clinical spaces, and then some community resources. And again, please feel free to throw in questions and so forth, and or shout out at me as we go along. Oh, geez. Okay. All right. So you all know suicide rates are high and unfortunately rising. But what's important, I think, to just start off with is that we know that firearms are the leading method used in the United States in adults. About roughly half of all suicide deaths in the US are by firearm. So we can't talk about reducing suicide without talking about the guns. I think probably most of you already know this, I hope you do, when we think about the breakdown of both fatal and non-fatal. So fatal suicides, as I mentioned, about half are by firearm, followed by suffocation or hanging, and then poisoning. And the non-fatal attempts, which is what we see in the hospital mostly, there's only a tiny sliver of firearms there. What we see more of are poisonings and cuttings. And this, in some ways, is a challenge because I think clinicians don't always think about the firearms because, to be honest, we don't see those patients because they usually don't survive to the ER. So part of this is educating clinicians on why it's important to think about the most lethal methods because those are the people who are often dying at home, and yet we have an opportunity to intervene. When we think about lethal means access, lethal means safety, reducing access to lethal means, what is it? Well, one way to think about this is if you think about sort of trajectory of suicide risk, recognizing it's not always a linear process. We know there are sort of upstream risk factors. Often there's ideation and then intent leading to an attempt, which either then leads to survival or death. And when we think about reducing access, it's really two pieces. So ideally, we are delaying and delaying the attempt, delaying the sort of contemplation piece so don't worry too much about where all the arrows are going in this, but delaying permanently, hopefully, or at least temporarily, because you're putting time and space between someone and a lethal method. People often say, well, they'll just pick another method. Okay, I mean, we know actually most people don't substitute another method, but even if they do, they're more likely to survive because if the gun is locked up and they take a handful of Advil instead, they're far more likely to survive. Even if they have a Tylenol overdose, we can treat that. So when people say, why are you picking on the guns? It's because they are so lethal. That's why we really need to be focused on them. And we know that lethal means approaches work. Hopefully many of you have heard some of these examples in the past. So Sri Lanka, for example, where pesticides were the leading method of suicide, there were policy changes banning the most toxic pesticides, and suicide rates dropped. In Britain, domestic gas was the leading method. They actually changed the gas, not for suicide prevention reasons, but for other reasons, but they saw that suicide rates dropped. And then the Israeli military has an interesting example. It's not a perfect translation to US populations, because in Israel, there's very low rates of personal firearm ownership. So basically they found when soldiers had to leave their guns on the base, when they went home for the weekend, suicide rates over the weekend dropped because they no longer had access to guns. So these are just some of the examples. There are others, and we know that lethal means safety approaches work, which is why it's part of zero suicide initiatives. The reason why it works, again, I hope many of you already know this, is because we know that the final decision to attempt suicide often occurs within minutes to hours. It's a famous study of people who survive near lethal attempts, and they asked them, what was the time frame from when you decided to attempt to when you took action? And the majority of people was within 8 hours. So when we're talking about reducing access, it's not a permanent change. It's not changing someone's lifestyle, asking them to change their identity. It's very much about temporary, voluntary, short-term changes. We also know that most people who survive an attempt or have suicidal thoughts do not later die by suicide, so it's not inevitable. I think you all know that. But as I alluded to earlier, guns are the most lethal method, so 85 to 90% lethality. So that's why we really focus on it. I will touch on medications a little bit today, and I'm happy to discuss that more if people have questions, but most of this will be about firearms. And there's tons of data on the state level, looking at all kinds of suicide rates, and basically when there are more guns, there are more suicides, so that we know that a gun in the home about triples the risk of completed suicide. But it's really important for us to recognize and believe that the presence of the gun is not somehow triggering suicidal thoughts. It's not that people who own guns are more likely to be depressed or even suicidal. It's just in that moment, in that crisis, if they can reach for a lethal method, they are more likely to die. Okay. In this talk, I also usually like to have a very basic firearms 101 section, recognizing many people don't really know anything about guns, and that's okay. I think you certainly don't need to be an expert, but sometimes it helps to know a little bit of terminology so you feel a little more comfortable. Basically, there are two kinds of guns: handguns, which are you hold in your hand, and sort of the two in the middle, so pistols and revolvers. And then long guns, which can be shotguns, rifles. They look like all different kinds of things. For our purposes, it doesn't really matter. The reason it can matter is because it can affect how you store weapons. So for example, a long gun is not going to fit in a small safe next to the bedside. So like, if you just think of it that way, so you don't need to worry about the specific type, make, model of what patients have, but just knowing there are a lot of different types out there. There are a lot of guns out there. So, and this is data from now a couple of years ago. We know that firearm sales spiked during the COVID pandemic, and there's a lot of concern that many of those individuals who purchase weapons are first-time gun owners and maybe less aware of secure storage practices. And so it's probably even more important for us to be thinking about this now. It's estimated probably overall about a third of adults in the US own a firearm themselves, and then another 10, 12% of people don't, but they live in a home with one. So I tend to just assume that my patients have a gun accessible, because I find that's an easier way to kind of ask some of the questions, so people don't feel singled out, but also because a lot of people do. And we need to recognize people own guns for all different kinds of reasons, and sometimes multiple reasons. So there are people who have weapons for their professions, whether they're security guards, law enforcement, so forth. Certainly people in the military. Many people who are in the military also own personal weapons, so we're not just talking about service weapons. The leading cause in the United States, or the leading reason given, is for personal protection. Most often a handgun, and that's going to matter for storage. But certainly, as I mentioned earlier with my father-in-law, there are lots of people who hunt, might store their weapons differently. And then there are lots of people who have them for sort of sentimental reasons, part of collections, and so forth. And many people have more than one. So also important to think about that in terms of storage. So perfect. I jumped ahead of myself. Oh, geez. So here's the leading reasons for owning guns from a national survey in 2017. This has changed over decades. 50 years ago, it was far more for like hunting or sport shooting. And then the personal protection piece has really grown. And these are some of the things that have been found in prior work to affect how people store guns at home, which matters because that's what we're talking about when we talk with patients. So there are geographic differences in terms of different parts of the country. People who have children in the home are more likely to store guns locked up. People who own handguns or guns for protection are more likely to have one loaded and unlocked or quickly accessible. Also, people who've carried in the last month political affiliation. And then importantly, and this is where we all come in, people who believe in the idea that, believe in the data, not the idea, that having access to a firearm increases the risk of suicide death, are more likely to store guns securely. So this is where we can help change some of those beliefs and ultimately, hopefully have more secure storage behaviors and hopefully prevent some fatal suicide attempts. Continuing Guns 101, as I mentioned, lots of kinds of guns. There are lots of ways to store them. You do not need to know all the ins and outs here. But one thing I do want to point out is so cable locks, that's the lock up at the top, the red thing that looks like a U-lock. So many of us, myself included, love to give those out because it feels good. It feels good to give somebody a free thing. They can cost only $1. The downside is that to use a cable lock, the gun has to be unloaded. So for people who have guns for personal protection, that really may be a non-starter. And they actually are fairly easy to cut or break into as well. So I think of cable locks as a short-term solution or a reminder, some swag to get people to remember kind of what they should do when they get home. Ultimately, though, sort of quick access lock boxes, like the ones at the bottom of the screen, or safes are probably what more people will actually be willing to use. And I think that matters if we think about, our hospitals providing devices, providing discounts and so forth. We can't assume that if we're handing out cable locks, everybody's actually locking up guns at home, because it's probably not true. So we think about in-home storage options for people when someone's at risk of suicide. There are lots of ways to do it at home. The most important thing is that the at-risk person can't have access. So they can't have the key, they can't have the passcode, right? The spouse has got to change it, et cetera, et cetera. What's often recommended, though, is moving guns out of the home because it puts more time and space between a person who's at risk and the weapon. But this can get a little bit complicated legally. In Colorado, you can transfer a firearm to any immediate family member with no background check required. So that's brothers, sisters, spouses, parents, adult children, sort of people who are actually kind of first-degree relatives. In Colorado, you actually can't just give your gun to your neighbor because within 72 hours, you would need to complete a background check or have it returned. And so the reason this matters is that if you're counseling a patient and you say, why don't you just give your gun to someone, give your gun to your neighbor, responsible firearms know what the law is. And if they know that you have just suggested they commit a felony, you will lose some credibility. So I think it's helpful to at least know enough to be able to say, make sure you know what the rules are. I also, as a clinician, want people to be safe at the end of the day. And so if they're making a decision because they know that this is the way to be safe, I don't think there are a lot of cases of prosecution around firearm transfers when they're for suicide prevention. But the current law doesn't have a sort of exception clause for waiving background checks when it's for suicide prevention. And then we also talk about storage with law enforcement and with retailers, which I'm going to come back to later. Background checks, I'm going to kind of flip over. I can come back to this if people are interested. It comes into play when you're thinking about storage out of the home with a non-family member or someone else. And basically, it doesn't cost that much, but it has to be completed before you transfer it. And it's sort of one additional layer that might be a barrier for people. Okay. Switch that. Okay, I'm gonna skip over those. Sorry, but happy to come back if people have questions about it later. What do we do in the clinics? Okay, so that's hopefully we're all up to speed for people who weren't before. Hopefully, we're in the same space. So how do we engage and encourage people, and then how do we remove obstacles? I'm not going to be talking about safety planning in depth. Clearly, lethal means counseling is part of safety planning. So I want to highlight that. And the intent of my talk is really to help us drill into the lethal means piece, whether you're doing it as part of safety planning or as a standalone. We know that counseling may affect home storage, particularly when the counseling is for parents of at-risk adolescents. And yet we also know that it often is not happening. And I think some of that might be documentation. I think a lot of that is that clinicians really just haven't been trained. When I was in residency 12 years ago, we didn't talk about this at all. And so I think, some of the social workers, other behavioral health specialists may have gotten training by now, but a lot of other ED providers still haven't. And that's true also of outpatient settings, outpatient providers. And there's all kinds of barriers, like people don't want to talk about guns, they don't have time, et cetera, et cetera. There are a lot of stresses in the healthcare system right now. There's some work showing that places that have protocols around lethal means counseling are more likely to have that counseling documented. I think we all know, right, that having pathways and protocols and reminders for clinicians can really help. And so the take-home message, in my opinion, for clinicians is that it's really like the designated driver model. It's about temporary voluntary changes to help somebody get through an at-risk period, to help them be safer while they're getting help for their mental illness, substance use, social stressors, et cetera. And so the safest is out of home. The backup, as I mentioned, would be locked storage in the home. And people are okay with this. Like in national surveys of patients, the majority say, yes, it's appropriate for healthcare providers to be talking about firearms when it's appropriate to the context, like suicide risk. What do they want? They want it to be patient-centered, the way they want everything to be patient-centered, right? They want to feel like individuals, but not singled out. They want advice, but they don't want to be lectured or told what to do. And they want us to be knowledgeable, at least about the basics. We did a study a couple of years ago where we sort of tried to dig into what is it that people really want around messaging. And I think probably none of this will come as a huge surprise, but I think it's helpful to kind of explicitly state it. So understanding and respecting the identity of someone as a gun owner, that the culture of safety, of wanting to protect and help other people, and using some of that language, that the responsible thing to do right now, or I know you care about protecting your family, but right now they really need you, et cetera, et cetera. Engaging trusted messengers. This is where community groups, firearm retailers, other individuals from the firearm community can really come into play. The voluntary temporary aspect of this, not using words like restriction or confiscation or anything that smacks of kind of legal action. And then context and motivation. So I'm mostly focusing on guns for the reasons I explained. But we have heard from people that it's helpful to also talk about medications and talk about other home hazards, because then it makes people feel like it's a little less singled out. And I think that's fine to say, also let's talk about what access to medications you have at home, and so forth, even though we know that the guns are the most lethal. Yeah, and so for example, don't say lethal means restriction. There's work showing that people prefer the term lethal means safety because it smacks less of legal action. So these are some example prompts. So what do you think about storing your guns off-site? You know, some of these are more in the context also of kids or domestic violence, where all of these issues overlap, but not wanting to kind of use words like give up, remove, dispose of, and so forth. I do also want to point out that there's some interesting work showing that for some people, the issue is not so much the asking as the recording in the medical record, because of a fear that somehow the responses will be linked to a government database of who has firearms. Very often in the context of suicide risk, it is important that we be asking the question and actually documenting. My opinion is that for other settings like pediatric practices and so forth, if they're doing universal counseling, that perhaps they could provide the counseling without actually asking, if that's a way to sort of not concern at least some people. Okay, so as I meant, and I have not been following the chat, is there anything I should ask, answer yet now, Conway? Sorry. Oh, let's see. Percent of counseling for those who didn't. No, we don't. Matt, that is a great question. We don't know. We know a lot of people are seen in an ER in the month, you know, prior to suicide death, but we don't know in adults what the actual effectiveness of counseling is in terms of behavior or subsequent attempts. That's a good question. Okay, so Lock to Live is a tool that we built as part of an NIH grant. You are welcome to use it. It is free. We do not get money for it. It was created with public dollars, and we're just happy to have it out in the world. And I'm going to just spend a minute kind of walking through what it is. So this is sort of the overall layout of what the tool does, and it's at locktolive.org and at that QR code. So it starts with a kind of opening section, and it's intended for adults with suicide risk and their family members. It's something that we designed specifically so, say, ER patients could look at on like a tablet or even their phone while they're in the ER waiting to be seen by someone. It's not intended to replace lethal means counseling, but it's intended to be an adjunct to it. So it starts kind of with a lot of the background I just went through and sort of trying to engage and educate people and help them understand the rationale. It then asks questions around whether there are usually firearms around, and if so, it leads people through a series of screens that have them sort of think through what they would prefer for storage, what are their own values around moving guns out of the home versus not, the financial issues in terms of the cost of different solutions, and then it sort of nudges them into picking what they want to do. So these are, for example, the preference questions. Are you open to storing guns out of the house? Are you concerned about cost? Do background checks? Are you worried about that? Is that a pragmatic barrier for you? There's a similar section, a little bit shorter, but for medications, thinking about which medications could you lock up, which ones do you need a small supply of out, you know, for emergency medication and so forth. It has some information at the end about home safety. And then it has a sort of reminder of here are the things that you chose, here are the next steps, here are some resources, and it has the option for people to print it. Importantly, you can't actually email it to yourself because that would record a copy somewhere linked to the person's name. And so we very intentionally did not include that as an option because it's completely anonymous. You know, we can see IP addresses or when people log in, but we have no idea who's filling it out. So people can in the sense that then it is completely confidential. And this is just an example of kind of one of the options. Just so you know, these questions with the cursors, it doesn't actually change the information that people get. It's just that the act of having to do something kind of makes people think more about it, if that makes sense. Another example of what the sort of checklist looks like in terms of what your options are and what the pros and cons would be. These are what the medication and the home safety screens look like. Some of the other things that really went into the tool were making sure that we were emphasizing hope and messages of hope, because we know that's so important. Encouraging help from someone they trusted, so who's somebody else who can help you in this process. And then normalizing both the suicide risk, that lots of people go through tough times, but also normalizing storage changes. And then the confidentiality piece that I already mentioned. So Lock to Live is currently so we tested it in a pilot trial in 3 emergency departments at Memorial, Denver Health, and University of Colorado, and found it had very high acceptability. Firearm owning patients with suicide risk said they would recommend it to others. They felt it was respectful, etc. It's currently being tested in 2 large trials in the Kaiser healthcare system, one in Kaiser, Colorado, and one in Kaiser, Washington. Those are with different populations, primary care with at-risk patients, and then outpatient mental health. And so those results should be coming soon. And one of the things I think is really cool from the Kaiser, Colorado study that they found is that providers actually really liked it, because the providers felt like they learned something from it. And so that wasn't the original intent of it, but that's great if it's providing some additional information for providers to help them feel better about doing the counseling. That's a bonus. And the Kaiser, Colorado study that again will have results hopefully within the next few months, also looked at methods of delivery. So for patients who screened high on their suicide risk screener in primary care, they then tested delivery. So should it go through the Kaiser sort of online health connection, via text message, provider referral, and so forth. And so stay tuned for some of that and thinking about how to roll this out. I will say one logistical thing we ran into in implementing it in our emergency department was the printing piece, because you have to be on the hospital network to print off a ED computer. So just something to be aware of if you think about wanting to roll this out with tablets or something. That was a piece I definitely had not thought about before we did it. We eventually figured it out, but it means if a patient's doing it on their phone, they can't then print it, obviously. And I would love if this was somehow at some point integrated into safety planning. I think there are a lot of ways to think about doing that in terms of different safety planning apps and so forth. We have not yet integrated it into, say, Epic in a way that gives providers prompts, because it's really patient facing. But I think that's another interesting sort of question. Again, happy to talk more about this. We were thrilled to develop it. We're not making money off of it. It's free to use, and it's in English and Spanish. Okay, so in my last couple minutes, I do want to talk a little bit about out-of-home storage. I want to come back to this. This is one of the other fun things we've been working on. So, I think in practice, we often say, well, you could store your gun with law enforcement or at a gun shop, at a local retailer range. But how often is that actually possible? So this was a prior study in the 8 Mountain West states. And basically, overall, about 3/4 of law enforcement agencies said they would offer storage, and about half of gun shops. You can also think about places like pawn shops, armories, or self-storage units are another place. And you can see here there's sort of some variation that, for example, law enforcement was more likely to say they would offer storage if the concern was about mental illness, versus visitors coming or traveling. It's kind of why the retailers were perhaps more engaged. This first work raised some questions about barriers, specifically liability. Sort of, how do I know the person's okay to get their gun back? I'm not a psychiatrist. Like, how do we, if they store it because they're suicidal and they come back to get it, what happens if I give them the gun and something happens? I think that's a really fair question, and it's one that we're still digging through and don't have an answer to, but it is an issue. So we wondered, though, Sarah Brandspiegel is on my team. She's wonderful. And she had this thought, well, maybe some of it is that people don't know where storage is. What if we made a map? So this was a sort of proof of concept project about 2 years ago. It's on the Colorado Firearm Safety Coalition website. This is a map showing all of the law enforcement agencies and retailers who said, I'm willing to consider storage. We called them all, actually a student called them all, and explained the process. It's just a listing. So these places follow their own rules. They cost different of money, they have their own procedures and so forth, but it's intended to be a sort of resource for the public. So certainly I encourage you to use it to look up places in your local area that are willing. And there may be some who aren't on here because it may be that at the time they were not interested and they may have changed and so forth. We have some funding right now from the NIH to dig into this a little bit more because people got really excited. So there are now maps in Mississippi, Washington State, Maryland, and New Jersey. But we don't actually know if they do anything. So people are trying to understand more what are the barriers, as well as what can we do to encourage places to provide storage? What are the specific issues they're worried about, like liability? I also want to mention extreme risk orders, since this is a newer and big issue in Colorado since January of 2020, an extreme risk order law in place that allows family members or law enforcement, actually it's family or room or housemates if you live together, or law enforcement, to request that firearms be temporarily removed from someone because of imminent risk of self-harm or harm to others. Our group created this graphic because we wanted to emphasize that it's part of a trajectory. Ideally, you can use some of these voluntary options first, but if a family is really at wit's end, or if there's no family around, or the person's not willing, et cetera, if there are other things going on, an extreme risk order is an option. Healthcare providers cannot request them. So we can tell family about them, or we can talk to police, but unlike in some states, we actually can't request them. That's kind of all I'll say on that note, but I think it is important for us to know that it is an option. In my opinion, it should be the last choice option, that really when nothing else has worked. And in the last couple minutes here, I want to talk a little bit about some of the sort of higher level community efforts that are going on, because I think there are a lot of opportunities for public health and healthcare organizations to get involved in these. And it really, I think, can help the clinical care that we provide to patients. So the first is gun shop projects. In Colorado, our coalition does not run the gun shop project. We are part of gun shop efforts in our state. CDPHE has done a phenomenal job in engaging firearm retailers and ranges across the state. I think in every county now, maybe Conlin may know, but I think it's expanded to every county. And these are programs that basically are voluntary for ranges and retailers to have information about suicide prevention in their shop. They're trusted messengers, safe spaces to talk about it, but it's a way to really help get that messaging out to people who may not have heard it. The coalition we started in 2015 and has been really fun and phenomenal and interesting, and it just keeps changing, and it's great. If you're interested, please let me know. We're a loose coalition of individuals, so there's no official sign-on process. You can come and you're not on behalf of your organization or anything. But some of the things we've done are, for example, presentation on suicide prevention at Ladies' Night. Probably one of my favorite events, where, it was a lot of women who were very knowledgeable about firearms, but had not heard the basics about suicide prevention. Like, is it okay to ask if someone's struggling? What do I do about my teenager? The sort of suicide prevention 101 that we really need to get out to the community. And it was great to be able to do it in this particular context. We've also done some trainings around firearms and how to talk about firearms for healthcare providers. That's the picture in the bottom right. Those are all doctors who I work with who came to learn about guns so that they could talk about them in a more informed way. And I'm actually gonna, I think, skip through these. Oh, actually, sorry. I won't skip through all of them. Sorry. So gun shop projects, there are other materials out there I just want to highlight that's really cool happening at the national level for anyone who thinks that these topics are too sensitive. There's really great work happening. So this is an example from the National Shooting Sports Foundation and the American Foundation for Suicide Prevention. Some of the materials that they put out that they've sent to all of the firearm retailers who are part of the National Trade Association. Another example, examples from the Department of Defense. So DoD is doing a lot of this work and really leaning into the importance of talking about firearms as part of a comprehensive suicide prevention program. I'll put the link to the PSA in the chat, but there are some great PSAs out there. Office of Suicide Prevention did one as well. This is one from Wyoming, oh my goodness, from Utah, that is, really about, again, he basically says, I was going through a rough patch. My buddies said they wanted to hang on to my gun for a while. I think they saved my life. And then he goes back to shooting. And it really hits on all of those things I mentioned before about temporary and voluntary changes with people you trust, and then really engaging messengers and getting the messages out. There are also PSAs and training videos from the VA, and then some, other ones that are out there if you want to learn more about firearms storage and firearms sort of 101. Okay, I'm going to skip those. Walk the Talk America is a really interesting organization that I encourage you to check out. I do some work with them. I'm not a paid consultant or anything. I just think it's pretty interesting what they're doing. So it's run by two guys who are in, I think, Nevada and New Jersey, from the firearms world. So one used to be in a firearms distributor, and then the other is a mental health professional outpatient and gun owner himself. And they're really trying to bridge the domains. So to get mental health care providers more comfortable talking about guns, but also to get firearm owners more comfortable talking about mental health and what does it mean to see a therapist, what happens to your gun rights, et cetera, et cetera. Those are pictures of ladies' nights, and yeah. So, okay, I'm good. I left a little time for questions because I was hoping that people might have some. I know I just went over a lot, but I hope it helped to explain some of the background and get us all on the same page. I think there's lots of opportunities for us to improve the communication counseling programs in our clinical settings, including how we link to community resources and how we use our community partners to help get those messages out. And so with that, I am going to stop sharing. I'll put my email in the chat in case people want to contact me, but I'm happy to answer any questions. And oh yes, okay, a couple things I see in the chat. Yes, so thank you, Nicole. The El Paso County PSA is fantastic. I forgot to mention it. That's a new one. Thanks for putting that link in. And I am happy to share the slides. It's a big slide deck because of the pictures, so I'll probably share them as a PDF, but if you need them or want them to share like with your, give as a talk, please reach out to me and I'll figure out how to get that to you. Other questions from folks or anything I can clarify? Yeah, perfect. So, I think one of the things we know more about counseling parents of at-risk adolescents than we actually do for adults in terms of how to change behaviors. I think it's actually it might be harder to get adults to do something for themselves than for their kids. I think parents and guardians typically get the sort of need to protect kids. So I think a couple things. There actually is a version of Lock to Live called Lock and Protect that's, I think, going to be released very soon. That's specifically for parents of adolescents who are at risk of suicide. And I think a couple of things in there. So one is emphasizing the sort of roller coaster and sort of waves of emotions that especially teens can have, and sort of helping parents understand what suicide risk is. Particularly true, I think, in homes where a kid may have been trained in firearm handling. So to help parents understand the importance still of locking things up. It's really hard to talk about strangulation options because there are, let's just be honest, like so many options. But that's important to talk about with parents. One piece I forgot on the firearm piece for adolescents is we know that when adolescents use a firearm for suicide, something like 85% of the time it's the parents or from within the home. So it's important parents know that. And then for medications, parents often don't think about that. So important, to lock things up. I've heard debates back and forth about, do you leave out non-toxic things in case the kid wants to attempt with something? That gets into a difficult, nuanced conversation. So in some ways, I think it can be easier to just try to lock up everything. And then with parents, the other important piece is the supervision piece and just helping them understand. I think that kids really should not be alone as much because it's so hard to reduce access to everything. I hope that helped. I'm sorry to hear Rocky Mountain Gun Club closed. Yeah. Have any? Okay. Thank you. We will update that, Jennifer. And Nicole, thank you. Eric Wallace is phenomenal. Really a huge champion for this work, and I love working with him. And that's super what you guys are doing in El Paso. Yeah, it's really, I think, such a great example of what we can be doing together. I mean, even in a community where firearm rights are really important and it might feel controversial, the coalition that has come together in El Paso is phenomenal. And so just so people know that the PSA includes, like, I think it's like the chief of police and sort of other prominent military and law enforcement people. Conlon, I'll put in the link to, or hopefully people know, the Office of Suicide Prevention has phenomenal resources about firearm work. And then Larimer County also, I think you guys actually have that on your website, but so here's the CDPHE resources with, oh, Conlon's having some tech stuff. Okay. So this is the link to CDPHE did, as well as some of the other things I highlighted. And I think, let's see, oh yeah. So Larimer County also had a really phenomenal program that they focused on youth suicide as well as preventing firearm theft. And I think another example of a place that, is pretty pro firearm rights, but said this is a problem in our community and this is something we can do, and it's not gun control. So I think those are great examples of what's happening. Okay, I'm going to put that's my email address. If anyone is interested in coming to a coalition meeting or just reaching out for anything, we're happy to. I didn't say a bunch about the initiative, the Firearm Injury Prevention Initiative at CU. It's really trying to help network, coalesce, and grow work in firearm injury prevention that's happening. We'll be excited to work with the Office of Gun Violence Prevention when it officially launches. And so we're always happy to just help connect people with what's going on. Working for firearm safety for the general public. Oh, great. And thank you, Lena. Jennifer, are you talking about like firearm safety specifically around suicide prevention or general firearm safety?
So around suicide prevention. So part of the CNC work that we're doing in Mesa County, which several other counties are as well, is a lot of education for just the general public around lethal means safety. And we're having a hard time finding anything that's not, for clinicians, like in a clinical setting.
Yeah. And are you looking for a curriculum like for like a 1 hour course kind of thing? Or are you looking for like handouts and videos and things?
I think we're looking for both. We need to, talk to employers about their wellness plans, and that needs to include lethal means safety. Same with school admin and staff. In addition to lethal means safety, we're just looking for any and all.
Yeah. So off the top of my head, I might say that the El Paso and Larimer County videos might be a great place to start. And then El Paso, and Nicole may know this more, but I think has been doing work around public education as well. That's Colorado centric, because I do think the Colorado piece really helps people feel like it's, whatever, connected local to them. And then for the youth piece, or sort of for other resources, the NSSF AFSP work, I really like to send people to, and they have a new, if you look under, I think it's toolkits, they have a new, oh, here we go. So they have work specifically for parents, and I think it's the protect those around you. So they have work for parents, firearm owning parents, on the importance of protecting teens from suicide. And again, I find that that's just helpful because it's coming from a big trusted organization. Yeah. Awesome. Thanks, Nicole. Great. But if you're looking for things, please feel free to reach out, because if I don't know, I'll just say I don't know, but there's lots of things happening in different states and around our state, and it's the more we can work together, the better. All right, I'll turn it back over to OSP. Maybe Conlon's back on. I'm not talking. Oh, we have no audio. Okay. I don't know. Are we done? Okay. Well, thank you so much for everything you guys do, especially in really difficult time. And I'm happy to be a resource if I can be helpful. Thanks for having me today.